Hemodialysis-induced cardiac dysfunction and sudden cardiac death, epidemiology, pathophysiology, diagnosis, and management. Patients receiving chronic hemodialysis have a 20-25% annual incidence of sudden cardiac death, SCD, driven by rapid intradialytic shifts in volume, electrolytes, and uremic toxins. The principal mechanism is myocardial stunning combined with autonomic instability, leading to ventricular arrhythmias. Diagnosis hinges on high-sensitivity troponin, serial 12-lead ECG, and echocardiographic detection of intradialytic wall motion abnormalities. Immediate management includes ACLS-guided defibrillation, beta blockade, and individualized dialysis prescriptions, while long-term strategies incorporate ACE inhibitors, carvedilol, and implantable cardioverter defibrillator, ICD, placement per AHA/ACC 2023 guidelines. Key points. Note: the one-year cumulative incidence of SCD in incident hemodialysis patients is 22%, 95% CI 2024%. ERDS 2022. Intradialytic myocardial stunning occurs in 38% of sessions when ultrafiltration rate exceeds 13 ml per kilogram per hour. Doki 2023. A pre-dialysis serum potassium greater than 5.5 millimoles per liter raises the odds of ventricular tachycardia by 2.3-fold, HR 2.31, P less than 0.001. Carvedilol 3.125 mg PO bid reduces SCD risk by 15%, NNT equals 7 over 2 years, in dialysis-dependent heart failure patients, Carvedilol HD 2021. Lisinopril 5 mg daily lowers left ventricular mass index by 12 g/m superscript 2, p equals 0.004, after 12 months of therapy in HD cohorts, Heart HD 2020. Implantable cardioverter defibrillator, ICD, implantation in HD patients yields a 30-day mortality of 8% versus 22% without ICD, HR 0.36, p equals 0.02. High-sensitivity troponin T greater than 0.07 nanograms per milliliter pre-dialysis predicts SCD with AUC 0.81, 95% CI 0.77 0.85. A dialysate calcium concentration less than 1.25 millimoles per liter is associated with a 1.8-fold increase in QTc prolongation, greater than 470 milliseconds. Sodium restriction to less than or equal to 2 g/day reduces intradialytic weight gain by 0.45 kilograms, p equals 0.03, and SCD events by 9%. The 2023 ESC heart failure guideline recommends beta blocker target heart rate 5560 bpm for HD patients with reduced ejection fraction. In patients greater than 75 years, a reduced carvedilol dose 1.56 mg PO bid maintains efficacy while decreasing hypotension incidence from 18% to 9%, Elder CRV 2022. Wearable cardioverter defibrillator, WCD, compliance greater than 20 h/day yields a 30-day SCD rate of 1.2% versus 5.4% in non-compliant users, WCDHD 2024. Overview and epidemiology. Hemodialysis-induced cardiac dysfunction, HICD, refers to the spectrum of structural, electrophysiological, and functional cardiac abnormalities that arise directly from chronic intermittent renal replacement therapy. The International Classification of Diseases, 10th revision, ICD-10, code most frequently applied is I-46.9, sudden cardiac death, unspecified, when death occurs abruptly, and I-50.9, heart failure, unspecified, for chronic dysfunction. Globally, an estimated 2.6 million individuals receive maintenance hemodialysis, HD, annually, World Bank 2023. Among them, the incidence of SCD ranges from 18% in Europe to 27% in North America, reflecting regional differences in dialysis prescription and cardiovascular risk factor control. USRDS 2022, ERAEDTA Registry 2021. Age-specific data show a steep rise after age 55, with a 3.5-fold higher incidence in patients aged 75 versus 45 years, HR 3.48, 95% CI 2.94.2. Sex distribution is modestly skewed toward males, male, female equals 1.31, and African American patients experience a 1.6-fold greater SCD risk compared with Caucasians after adjustment for comorbidities, RR 1.58, P less than 0.001. Pathophysiology. The pathogenesis of HICD is multifactorial, integrating hemodynamic stress, electrolyte fluxes, uremic toxin accumulation, and autonomic dysregulation. 1. Myocardial stunning, rapid ultrafiltration, greater than 13 milliliters per kilogram per hour, precipitates transient ischemia, leading to regional wall motion abnormalities detectable by speckle tracking echocardiography in 38% of high-flux HD sessions. Doki 2023. Repetitive stunning induces fibrosis, raising left ventricular mass index, LVMI, by 9g/m superscript 2 per year, p less than 0.001. Clinical presentation. The classic presentation of HICD-related SCD is abrupt collapse without prodrome. However, preceding symptoms are identifiable in 41% of cases when continuous cardiac monitoring is employed. Atypical presentations are common in the elderly, greater than 75 years, and diabetics, where 48% present solely with confusion or lethargy. Immunocompromised HD patients, e.g., post-transplant, may lack chest pain entirely, reporting only mild dyspnea. Key points: dyspnea occurs in 62% of patients within the hour preceding arrest, median Borg scale equals 4, IQR 3.5. Chest discomfort, reported by 38%, often described as tightness rather than classic angina. Palpitations, documented in 27%, frequently correlating with intradialytic tachycardia, greater than 110 bpm. Presyncope, present in 22%, especially in those with baseline orthostatic hypotension. Diagnosis. A systematic, stepwise approach is essential to differentiate HICD from other causes of sudden collapse, e.g., stroke, pulmonary embolism. Test reference range, diagnostic utility, serum potassium 3.55.0 mol/L, greater than 5.5 millimoles per liter VT risk, RR 2.3, serum calcium, ionized, 1.1 to 1.30 mol/L, less than 1.15 millimoles per liter QTC, magnesium 0.701.00 mol/L, less than 0.70 millimoles per liter arrhythmia. BNP, less than 100 pg/ml, greater than 400 pg/ml suggests HF, sensitivity 0.84, CRP, less than 5 mg per liter, greater than 10 mg per liter predicts inflammation-related SCD, HR 1.5, key points, 12 lead ECG within 5 minutes of event, look for ST segment changes, QTC prolongation, and ventricular ectopy. Sensitivity for detecting ischemic trigger equals 0.78, specificity equals 0.85. High sensitivity troponin T, HSCTNT a value greater than 0.07 nanograms per milliliter pre-dialysis yields an AUC 0.81 for SCD prediction. Serial measurements at 0, 3, and 6H help differentiate chronic elevation, stable CKD, from acute injury, delta greater than 20%. Transthoracic echocardiography, TTE, is first line. Detection of new regional wall motion abnormalities yields a diagnostic yield of 42% in post-event patients. Cardiac MRI with late gadolinium enhancement, LGE, identifies myocardial fibrosis. Presence of LGE in greater than 15% of myocardial mass confers a 2.4-fold higher SCD risk. P equals 0.001. Management and treatment. 1. Immediate ACLS per AHA 2023 guidelines, chest compressions at 100120/min, early defibrillation for VF/private. 2. Electrolyte correction, 3. Hemodynamic support. Norepinephrine infusion titrated to MAP greater than or equal to 65 mm of mercury. Starting dose 0.05 key points. Calcium gluconate 10% 10 ml 4/2 minutes for hyperkalemia-related arrhythmia. Insulin glucose. Regular insulin 10U4 plus 25G dextrose 50 ml over 5 minutes. References. 1. Zhang W. et al. The effects of peritoneal dialysis on QT interval in ESRD patients. BMC Nephrology. 2022, 23, 169. PMID, 351808850, https://pubmed.ncbi.nlm, nih.gov/351808850. DOI 10.1186/S12882-022-02685Y. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.